Hi guys, so let's discuss about abortions again. So in one of the previous video we have discussed a lot about missed abortion, but in this video I will be covering on all sorts of abortions like incomplete, threatened, inevitable, missed abortion as well, then septic abortion and diagnosis, management, treatment, everything. So what is abortion? Abortion is any loss of pregnancy before 20 weeks. If it happens after 20 weeks, it is called stillbirth. So what is so special about 20 weeks? Why not 18 weeks? Why not 16 weeks? Or why not 24 weeks? So the reason is that 20 weeks is considered the age of fetal viability. So it has been said traditionally that fetus can survive outside of the uterus after 20 weeks. Okay, but it does not mean that if the fetus is 20 weeks, then you can actually deliver the baby. It does not mean that. It is a traditional definition that we use for defining abortion. So any loss of pregnancy before 20 weeks is abortion. Any loss of pregnancy after 20 weeks is stillbirth. One thing I want to mention here is that we don't prefer to use the term abortion because there has been a lot of debate around the term abortion, especially induced abortion. Because all the sociologists, theologists, medical professionals as well are debating that whether choosing to kill the baby is good or not. So we prefer to use the term miscarriage or early pregnancy loss. Now coming to the stages of abortion, that is the most scary part of the topic abortion. That what is missed abortion, what is incomplete, what is threatened, what is complete, what is septic, and all those things. So these are the stages of abortion. We have given these some terms like missed abortion, incomplete abortion, complete abortion for the sake of convenience so that we can talk to each other as doctors. And yeah, so let's start with biochemical pregnancy loss. What is biochemical pregnancy loss? So biochemical pregnancy loss means that you are determining whether abortion has happened or not based on a biochemical marker, that is beta HCG. So it is the same hormone that you use in the urine pregnancy kits that you use at home. So that is beta HCG. So we all know that on ultrasound we can see the baby at 5 to 6 weeks of gestation. So how will we diagnose or how will we determine whether the baby has aborted or not before 6 weeks? We cannot see anything on ultrasound before that age. So we use this biomarker or the hormone called beta HCG. It should continuously increase during the pregnancy. So if it does not increase or if it decreases, that means there is a problem. So before 6 weeks, you measure a beta HCG at the baseline and you expect it to gradually increase. But if it has started increasing, then it starts decreasing, then there is a problem. That means abortion has happened. The mother has conceived or the lady has conceived, but the pregnancy could not progress due to some reason. So that is biochemical pregnancy loss, because we are determining the abortion or we are diagnosing the abortion based on a biochemical marker. So coming to missed abortion, we have discussed that before, but what is missed abortion? It is asymptomatic abortion, asymptomatic pregnancy loss. Why I am saying asymptomatic? Because there are hardly any symptoms. Mother will come to you for a regular antenatal examination. You will check her, you do an ultrasound and you find that the baby is dead. So that is missed abortion. But one thing to remember here is that although there are no symptoms, but one thing that you can see in this lady is regression of early pregnancy symptoms. What are early pregnancy symptoms? Like breast engorgement, urinary frequency, then there can be nausea and vomiting, little bit of abdominal discomfort. All these are symptoms of early pregnancy. If a lady had those before, but now she is not feeling anything, she is free of symptoms. So that means you should check whether it's a missed abortion or not, whether the pregnancy is progressing naturally or not. Because it may be very much possible that symptom may have resolved because she is taking some medications or doing some lifestyle modifications or anything. So you have to be very cognizant whether the baby is okay or not. So that is missed abortion. Coming to threatened abortion, it is not per se the abortion, but the pregnancy is at risk. So abortion is a process. It does not happen like that one day baby is alive and next second it is dead. It goes through a process. Like first the baby will be compromised. He or she will not get enough nutrients from the mother. He or she will not get enough oxygen from the mother. So in that case, the baby will start compromising basically. And At this stage, when the baby is okay, but he or she is not healthy, that is called threatened abortion. So mother will come to you and say that I feel something is wrong, or she may come for a regular antenatal checkup, and you see that beta FMGE are not increasing as they should increase. So in that case, you suspect threatened abortion. The good news is that in threatened abortion cases, 50% of the times you can save the pregnancy. So that is the good news with certain lifestyle modification. So mother should not engage in any aggressive sexual activity. Mother should not engage in any aggressive sports. So these kind of advices you should give to the mother. These lifestyle modifications give pelvis some rest, and baby can again become healthy, and beta HCG will start increasing as they should, and everything will be fine in 50% of the cases if proper precautions are taken. So that is threatened abortion. Now the thing to remember here is that in threatened abortion, cervical os is still closed. The opening of the cervix is still closed, so you can save the pregnancy. But what if cervical os opens? So this is called inevitable abortion. Only difference between threatened abortion and inevitable abortion is cervical os. Baby is alive in both these cases, in both these stages of abortion. So if cervical os opens, you cannot save the baby because there is no way to close the cervical os. So we have done biochemical pregnancy loss, missed abortion, threatened abortion, and inevitable abortion. Now coming to incomplete abortion. So once the cervix opens, that is inevitable abortion, but the baby is still alive. If the baby dies, that is incomplete abortion. Cervix is open, cervical os is open, but the baby is not alive anymore. That is incomplete abortion. And in some cases, the product of conception is other name for the dead baby. So in incomplete abortion, sometimes partial product of conceptions are expelled outside of the uterus. So on cervical examination, you can see those product of conceptions. So that is incomplete abortion. Coming to complete abortion, baby is dead and it has been expelled out of the uterus naturally, and cervical os has closed again. So that is complete abortion because the process of abortion has been completed naturally. Mother is okay, she will have no symptoms, she will be completely okay. But you still need to monitor her because she may be at the risk of bleeding or infection. You should make sure that she is stable and emotionally well. Okay, because suppose you give a news to a mother that she is expecting a baby after some months, and you say that baby is not there. He is not only dead, but he has been expelled out of the uterus, so you don't have a baby inside of your uterus anymore. That is a bad news. She may be emotionally very troubled, so you have to make sure that she is okay and she is stable, both physiologically and emotionally. So that completes the stages of abortion. Now, how will you manage the cases of abortion? We have already discussed the symptoms. In missed abortion, you will not have any symptoms. In threatened abortion, you may have little bit of symptoms. In incomplete abortion and inevitable abortion, you will have abdominal pain and vaginal bleeding. In complete abortion, again, you will not have many symptoms because baby has been expelled, passed out of the uterus, cervix has closed again. Yeah. So in septic abortion, what is septic abortion? I forgot to mention that. Septic abortion is when the process of abortion is complicated by infection. So any abortion when complicated by infection, that is called septic abortion. What you will see in septic abortion? Septic abortion, you will see fever, which is a typical sign of any infection, right? You will see uterine discharge, cervical discharge, purulent cervical discharge. Mother may be tachycardic, that is increased heart rate or increased pulse rate. Her BP would be low, hypotension. So these are the cardinal signs of any infection. You will see those. Now, how will you manage? Symptoms we have discussed. On physical examination, what you will do? First thing that you need to ensure is that mother is stable. Her BP is okay. She is not bleeding. So the general physical examination and the vitals you will take, and you will ensure that mother is okay. Whether she needs a blood transfusion or not. Because maybe she has undergone a lot of bleeding because of abortion. So she may be anemic. So you need to arrange for ABO typing and RH blood typing basically, so that you can transfuse her if needed. You will check the hematocrit, you will check the hemoglobin to ensure that she is not anemic. Then abiotyping we have already discussed, and RH immunotyping you will do because she may have been sensitized by this baby. Okay, we will discuss that in RH when we discuss the RH this thing, incompatibility and everything like that. But you will do the RH, okay, hematocrit, hemoglobin, and then you will do the physical examination. In physical examination, what you will do? In physical examination, you will do the complete abdominal examination after checking the vitals, and you will do the complete pelvic examination. Then you will do the bimanual speculum examination. You will use a speculum to visualize the cervix. I will explain why we are doing all these things. And yes, so then you will do the bimanual palpation. So on physical examination, when you do the abdominal examination, what you are looking for? So it is very much possible that this was an ectopic pregnancy. So, or I should say that we have to rule out the ectopic pregnancy, mainly the rupture of ectopic pregnancy, because that is a life-threatening condition. So if an ectopic pregnancy ruptures inside the abdomen or the pelvis, what you will see? There will be fluid coming out of the ectopic pregnancy, and that fluid will irritate the peritoneum. So you will see the rebound tenderness, you will see the guarding, you will see the rigidity, abdomen will be tight. So all these things, when you see, it means that there is rupture of ectopic pregnancy, or there can be extrauterine extension of any septic abortion. So if the mother had septic abortion, that is abortion complicated by any infection due to unsterile procedures, then what will happen? The infection will spread in the abdomen. So you will again see the signs suggestive of irritation of peritoneum. So you will have rebound tenderness, guarding, rigidity, and all these things along with fever, hypotension, maybe signs of shock, tachycardia, all these things you will see. So you have to corroborate the whole clinical picture. Now coming to the speculum examination or bimanual palpation. So what you will see there when you check the cervix, you may see the product of conception in incomplete abortion. Okay, and you may see the cervical os open, and that means it is inevitable abortion. So there are only two types of abortion in which you will see the cervical os open, which is incomplete abortion and inevitable abortion. So that's what you are looking for when you are doing the when you are looking at the cervical os during your physical examination. What else you will see? You may see a lot of blood. You may see a lot of purulent vaginal discharge in case of septic abortion. So that is what you are looking for during your physical examination. So one thing I want to mention here is that you will also notice the rate of blood flow from the vagina, because if it is too much, heavier than the typical menstrual flow, that means there can be a problem, and you should arrange for blood transfusion. You should do ABO typing, RH typing, and everything. That is about physical examination. Now coming to beta HCG and ultrasound. Although I will discuss these beta HCG and ultrasound in detail in the diagnosis of pregnancy, but let's discuss what you will see in ultrasound in cases of abortion. How will you ensure that baby is actually dead or pregnancy is not progressing naturally? So there are 4 findings. But first of all, let me tell you a little bit like in ultrasound how things develop, or how gestational sac develop, yolk sac and embryo. So first thing that you can see in on ultrasound in cases of pregnancy is the gestational sac. Then after a few weeks you will see yolk sac, and in that yolk sac the baby will develop. So the first finding is, if you are seeing the gestational sac but after 14 days also you cannot see an embryo, that means gestational sac has developed but embryo has not developed. So that is a problem. So if you see the gestational sac today and after 14 days also you cannot see an embryo, that's a problem. That's first finding. Second finding is, if you see the yolk sac but after 11 days also you cannot see an embryo, that also is a finding. Third is that if the baby is 7 mm in size, 7 millimeter in size, but you cannot see the fetal heart rate, that is the third finding. That means baby is no longer alive. Or if you see a gestational sac of 25 millimeter, that is 2.5 centimeter, but you cannot see an embryo inside it, that is the fourth ultrasound finding. Because gestational sac, if it is 25 mm in diameter, the mean diameter, is 25 mm, 2.5 centimeter. It is big enough to hold a baby, and baby should be there. If you are not seeing the baby, that's an abortion. So these are the 4 ultrasound findings. Now coming to beta HCG. Beta HCG should rise gradually, as I mentioned before. It should rise gradually during the pregnancy. It should double every 48 hours, or to be precise, 53%. It should increase, not 53%, it should increase, it should double every 48 to 72 hours. So that is how you measure the beta HCG. But if the beta HCG is not rising, then there is a problem. So you should corroborate it with the ultrasound finding. So if you can see the fetus, you should have the beta HCG level of 10,000 milli international unit per ml. When you see the gestational sac, it should be 1000 to 2000 milli international unit per ml. And when you see the yolk sac, it should be 2500 to 7200. So these are some of the values that you should remember if you want to. But the main idea is that you should see the beta HCG level rising, and you should corroborate these titers clinically as well as with ultrasound. So, okay, I forgot to mention the risk factor. I think I have mentioned it. Okay. So coming to the management. Now there are 3 kinds of management of abortion: medical management, surgical management, and expectant management. So let's start with the expectant management. What is expectant management? You don't do anything. That is expectant management basically. A mother comes to you and you diagnose that it is an abortion, but she's emotionally very troubled and she don't want to take any medications, she doesn't want to go on any surgery. Then what you will do? You will tell her that okay, you can let this continue naturally and the baby will be expelled in 1 to 2 months and everything will be fine, but you have to take care of certain things. So what things? We have to be very cognizant that infection should not develop while this expectant management is going on, and there should be no hemorrhage. There should not be any bleeding. Now these are the 2 main risks in medical management and expectant management, that is hemorrhage and infection, bleeding and infection. So if the mother is staying or the lady is staying very far away from the hospital or your clinic and the bleeding develops, she will take time to come to the hospital. So please consider this scenario that if she is living very far and she is living alone, there is nobody to take care of her, I would not prefer expectant management or the medical management, but it depends on the situation. So it should be a shared decision making. You should discuss with the mother whether she wants expectant management, medical management, or she just want to get rid of the dead baby. I am emotionally fine, I just want the baby to get out of my system. Then you go for surgical management. So it is a shared decision making basically. So this is expectant management. In medical management, what we do, we give 2 drugs. Like one is main, that is misoprostol. You give this drug misoprostol 800 microgram intravaginally. You put the pessary in the vagina and it will increase the uterine contraction and it will pass the baby out, expel the baby. So again, because uterus is contracting a lot with this drug, there can be risk of bleeding and there can be risk of infection, mainly bleeding but infection also. So we can use misoprostol, and if we give mifepristone, another drug, 24 hours before misoprostol, 200 microgram, then the chances of success are more. So you can give mifepristone 200 microgram orally 24 hours before misoprostol. Another thing is that if the baby still doesn't get expelled, then you can repeat misoprostol in once more, like within a week, 3 hours to 1 week to be precise. What other things you will give in medical management? You will give some NSAIDs for pain management, and if the bleeding is more, you can try to stop it. You're giving medication, trexanimic acid and all those things. After that, you will give RH immunoglobulin. It is very important. So if the mother had a RH positive baby or if she is RH negative, so baby blood will mix with mother blood during abortion. So fetal erythrocytes or baby's RBCs can sensitize the mother. Now she will have immunoglobulins. So it can become a problem in the next pregnancy. So this is called alloimmunization. If the mother gets immunoglobulins, this is called alloimmunization. So which we give RH immunoglobulin in such cases. Okay, so that the next pregnancy is okay. Another thing to remember here is if the abortion happens very early in the pregnancy, we may skip RH immunoglobulin. I'm saying this with word of caution, take it with a pinch of salt, check the guidelines, etc. But I'm just giving you a theoretical thing that if the abortion happens very early in the pregnancy loss, fetal erythrocytes may not have developed. So if the erythrocytes are not there, they will not sensitize the mother. They are not there. How will they sensitize? So in those cases, some guidelines says that we have to give RH immunoglobulin. Some say that we don't have to give RH immunoglobulin, depending on where are you practicing or what exams you are giving. Another thing is oxytocin is ineffective in first trimester because there are no receptors. So if the abortion happens in first trimester, there is no use of giving oxytocin. So that is medical management. Coming to surgical management, and one thing to remember, expectant management and medical management is not preferred after first trimester. If the woman is coming in second trimester, you will do surgical management. That is dilatation and curettage, suction curettage. So that's what you will do. And the complication of surgical management, you have to take care that you should not lacerate the cervix. You should not perforate the cervix, and you should expel the products of conception completely. Why? Because there can be uterine adhesions if the product of conceptions remain inside of the uterus. So you have to be very cautious that you expel the products completely and you do it under septic conditions, and you take all the necessary precautions to avoid infection. So this is about the treatment of abortion. Now I think I forgot to mention about the risk factors of abortion. So the risk factors of abortion, first is chromosomal anomalies in the fetus. So polyploidy or monosomies, diploidies and all those things basically. So chromosomal anomalies in the fetus can be one of the factors that can lead to abortion. Second is advanced maternal age. The older the lady is, the more are the chances of abortion. If she is in 40s or 50s, there are more chances that she will have an abortion. Then any additional pregnancy loss, any previous pregnancy loss, any previous abortion increases the chances of abortion more. Three things. Now there can be certain systemic diseases like thyroid problems, diabetes, hyperprolactinemia, celiac disease, and more importantly, this antiphospholipid antibody syndrome. So antiphospholipid antibody syndrome, if there is recurrent pregnancy loss, you should suspect antiphospholipid antibody syndrome. Then there can be certain infections like parvovirus infection, cytomegalovirus, syphilis. All these can increase the chances of abortion. Now, if the patient has any intrauterine device implanted inside of her uterus for contraception and she forgets to remove that, that will alter the structure of the uterus, the anatomy of the uterus per se. So that will increase the chances of abortion. Another thing, if there are any uterine anomalies, any uterine adhesions, fibroids, big fibroids basically, not small fibroids. If they are asymptomatic, pregnancies can progress with fibroids in place. But if there are big fibroids that are altering the structure of uterus, you should be cognizant that it can be a risk factor for abortion. Then there can be Mullerian anomalies, like any structural problem with the uterus. So that is one. Then there can be social determinants of health. If mother is under a lot of stress, if there is food insecurity, she is being abused, and there is a lot of violence at home, she is smoking, taking cocaine, having alcohol, or too much of caffeine even. So no amount of alcohol is safe during pregnancy, but it is being said that little bit of coffee is okay, but women should not drink more than 3 cups of coffee per day. So that is a risk factor for abortion. I think we have covered pretty much all, and thank you for listening. Thanks. I will see you in the next video.